Well, welcome to Chapter 6. This is the adrenergic or sympathomimetic bronchodilators. Remember, we talked about sympathomimetic meant that we're mimicking the sympathetic system. And so these are the part of the adrenergic bronchodilators. These are also known as your beta agonist or your beta adrenergics, okay? So we're just going to define what does it mean, define adrenergic, list available drugs that we have in respiratory therapy. Let's look at the different formulations, the different things that we have, and then basically how do these work? What's the important part about them that we have to understand? And we're also going to look how do we administer them. Most of them are going to be inhalation, but there's others that you can actually have tablets or liquid or something else with them, but the majority will be inhalation. There are adverse effects with all of our drugs. With this family, the major side effect is tremors. Patients will tell you that they have these fine tremors. They can tell when they've taken their medication because of these tremors. Sometimes the tremors get really bad and these folks have to have other medication to calm them down. Other times they last for maybe 30 minutes or a little bit longer and then they'll actually gradually go away. And then the question comes up, well, how do we know that we've done something good? How do we know that we have actually done something for this patient that's positive? And so with this, we're going to have to look at the clinical assessment with our patients. One of the things that you need to remember whenever you administer drugs to a patient, you always have to do pre and then post vital signs. And if you can, and most of the time, stay with the patient and watch to see what happens with them at that point. So some of the clinical indications for these: relaxation of smooth muscle airway in the presence of reversible obstruction. This is asthma, okay? Asthma can either be chronic or it can be exercise induced or it can be acute. Acute is it comes, it goes. Chronic is it's going to stay around for a long period of time. Exercise induced, we see this a lot of times with our kids when they're out there playing baseball and different things along that line, and they'll have problems with it. When you talk about diseases, you're going to talk about intrinsic asthma and extrinsic asthma. Intrinsic asthma are things in the body that cause the problem. Extrinsic is something outside. When sometimes with your kids, they're allergic to plants or things like that. They want to go play baseball, but they can't go play baseball because when they get out into the field where the plants are, their airways begin to close up. They eyes shut and swell, different things go on with it. That's all extrinsic. Bronchitis is another one. Emphysema is another one. Bronchiectasis is another one. When you talk about diseases, you're going to talk about what we call CFC BABE. And CFC BABE is basically cystic fibrosis, chronic bronchitis, asthma, bronchiectasis, and emphysema. And these are all obstructive diseases, okay? How do we know you have an obstructive disease? Where are you at this point? This is what you guys are talking about with TREACE and PFTs. We're looking for a 12% improvement after we give this medication to make sure that things are actually working. So some of the indications for these: we can reverse the airflow obstruction by giving them this medication as long as they don't have a problem with the medication. The problem is with all medications, especially if you take them over a period of time, you either can have tachyphylaxis, which is the rapid onset of a negative reaction, or they can build up a tolerance, which now means I need more and more of that medication to get the same results. So we have some short-acting agents. You can see non-catecholamines on here. The first agents we're going to talk about, though, are the catecholamines. They were the first ultra short-acting bronchodilators that we have. And then once we got a little bit better and able to do the drugs a little bit easier, then they became non-catecholamines, and now they're short-acting. So what does short-acting mean? Short-acting means they're going to last maybe 4 to 6 hours, sometimes with tablets or something else, maybe 8 hours. They're not the long-acting ones. The long-acting bronchodilators last up to 12 hours, normally BID administration for the most part. Because they have a fairly rapid onset, they're called our rescue agents, and sometimes they do call them relievers. Why are they rescue agents? Most of the time when you're taking these, they're going to onset in about 15 minutes. We see this sometimes when we give them as an inhalation, that with the small volume nebulizers, we'll sometimes see that reaction coming on a lot quicker at that particular point in time. But they're there to help rescue these folks. The two most commonly are albuterol and levalbuterol. It's interesting, albuterol and levalbuterol are isomers of each other. Isomers are interesting. They're actually the same formula. It's just a different arrangement of the molecules is basically what they are. Okay, so we have those two are the major ones that you're going to see at that particular point. We're going to have peak flow values that we can decrease with the increasing shortness of breath. Sometimes when you have to go to the hospital and you're having issues with your breathing, but you're not so bad that we have to think about intubating you or do something else with you, sometimes we'll do peak flows with you. And what we're doing with these peak flows is we're looking to see, are we getting reversal with the medications we're giving you, okay? The other thing too, and you'll talk about with diseases, you should have an asthma action plan. You can also have the same plan with chronic bronchitis. You can have the same plan with people who have COPD, chronic obstructive pulmonary disease. These action plans are designed to tell you what you need to do to make sure that you're going to survive whatever's going to go on at this particular point. This is something you sit down, you talk with your physician with, you have your peak flow meters, you know what your values are. One thing that's really, really important with the peak flow meters, and I know Teresa's told you this, is you have to set your values on a day when you're doing well. You cannot go to the hospital, be released from the hospital, and the next day set those values. Those are not going to work for you. You have to feel very, very well in order to be able to do these. So we also have our long-acting agents. These are the ones that will last for 12 hours, and there's a couple out there that are actually 24 hours. These were blessings for people, and it's probably the best way to put it. People, as remember if I mentioned to you, the more often you have to do something, the less likely you're to use it. Well, if you're in the middle of doing something and you start to wheeze a little bit and you're having a little tightness, if you're really having a good time, you're not going to stop to go take care of it because you don't want to lose what's going on at that particular point. We used to have this problem with kids going to school. The medication was kept by the nurse in the nurse's office. A lot of them were very embarrassed to say, I have to go get my medication. And so they wouldn't go to the nurse's office to get them, and they would get in trouble. And then you have to call 911, take them to the hospital, and go through all of that. Well, with the long-acting agents, what they basically did for us is you could take it before you went to school, and then you didn't take it again until 12 hours later. And as long as things were working appropriately and well for you, you didn't have to worry about trying to go to the nurse's office, okay? We call these either controllers or maintenance drugs, and you can see there's a number of them listed here: salmeterol, formoterol, aformoterol, and dacterol, all the rest of them at this particular point. About 6 or 7 years ago, the FDA came out, and what the FDA did is they did a black box around all these. And when you see a black box around a medication, it basically means this medication has a high mortality rate. It can kill you, okay? And they were planning on trying to take all of these drugs off the market. And then they came in and said, okay, what we're going to do then, you can continue using these drugs, but you have to mix them with the inhaled corticosteroids. The inhaled corticosteroids are going to help you with that and hopefully cut down the mortality associated with these. And then one of the things that they also wanted to do is they wanted to say, once you're better, stop these drugs and then just go back to your rescue drugs or do whatever else you have to. There's a little bit of a hesitancy to stop because the reason you got better is because you're on these drugs and you're taking these drugs that are maintaining you. So not many people were ever stopped, but we did mix them with the corticosteroids, and we did find out that the reaction was much, much better. And about 2 years ago, the FDA finally removed the black boxes from them. So one of the major big daddy rabbits of this whole field is racemic epi. That is the catecholamine that started this revolution, if you want to think about it. Okay. There's reasons for using racemic epi. Racemic epi works in the upper airway. That's your alpha, okay? They also work as the beta 1. Remember, that's your heart. And they work beta 2. There's your lungs. So it has a complete coverage of the body, if you want to think about it that way. So what do we use epi for the most part? Help to control bleeding during procedures that we do. So you're having a bronchoscopy and we're taking little bites and you start to bleed. We don't want to leave you bleeding. We want to stop you. And so we're going to give you epi. Epi, as with its alpha properties, is going to cause vasoconstriction. That's what we're looking for. It reduces airway swelling. There it is with that one. If you're on a ventilator and you have an ET tube, you can have some stridor with it. Epiglottitis and croup, these are two childhood diseases. Teresa's going to talk about those in pediatric. Very, very common, especially during the winter months, that we see these. Epiglottitis a little bit more serious than croup, but we can then go ahead and use the racemic epi. And here you see, here's your child with noisy breathing and stridor. Stridor, if you remember from patient assessment, is something you can hear without your stethoscope. It's in the upper airways. So some different formulations and agents that we have. You have the ultra short acting catecholamines. These are the medications that have a fast on, fast off. You can give some of these drugs, they're going to be there and act within 5 to 10 minutes. But the problem is they don't last more than an hour to 2 hours at the most. And so what happens is you have to continually give these medications so that they can work for you. The problem with doing something like that is these ultra-short-acting catecholamines had a beta-1 response in addition to the beta-2 response. And so the heart rates would increase. And the heart rates would not go down within the 2 hours or hour that these were working. So it was a really toss it up in the air. What are you going to have to live with at this particular point? From these came the short-acting non-catecholamines, and this is where your albuterol, levoalbuterol is. These last for 4 to 6 hours. These are more beta-2 specific than beta-1. They still have a little bit of cardiac issue with them. Levoalbuterol, one of the selling points of it is it had even less cardiac issues than albuterol. Most of the time, though, when you go to the hospital now, you're going to see albuterol rather than levoalbuterol. And then you have your long-acting ones. These are the ones that have to be given with the corticosteroids, and these are your mixtures that you get. These last from anywhere from 12 to 24 hours. You can see those different drugs. So the catecholamines, okay. So most of your bronchodilators are either catecholamines or derivatives of catecholamines. Why are they non-catecholamines? Because we changed the epi ring. That's basically what it is. So the catecholamines mimic epinephrine. You do have tachycardia. It does raise your heart rate. There's your beta-1 effect. Elevated BP, same thing. Smooth muscle relaxation. So you do get some of those tremors that you have with it. Some glycogenolysis, skeletal muscle tremor, and then it stimulates the central nervous system vasoconstriction. Vasoconstriction we see more in the upper airway than we see with the lungs because it causes bronchodilation in the lungs. So here's your isomers. They're called stereoisomers. And basically, like I said, they're the same formula. It's just a different arrangement that we do with these. Basically, as you can see, you cannot impose them on each other. If you think about it, your right hand, your left hand, if you look at them, you go, well, they look basically the same. But if you put them together, you find out they're really not quite the same. And that means they're not superimposable, okay? They have similar physical chemical properties. They have different physiological effects. The effects are mainly, when we talk about albuterol and levoalbuterol, it's the cardiac portion of them. If you talk to some of the drug reps that talk about this, they'll tell you, well, levoalbuterol lasts for maybe an hour or two longer than albuterol. True, false, it's hard to say. They're basically almost the same drug, okay? So with epi, it's a very potent bronchodilator. It has those alpha and beta receptors, and that's why you get all of these other things with it. We do, on occasions, we give folks with this. They will tell us that you get a headache, and they are awake. We stimulated that central nervous system, and these guys are still awake. Why would we use this? You saw the croup, the epiglottitis. In some cases, if somebody is really, really bad off and we need to do something, on occasions we'll go ahead and give them epi, and then we have to follow through with our other drugs because you don't want to continue doing epi because of all the side effects. Basically, remember, epi occurs naturally in the adrenal medulla. It has a very rapid onset, but a very short duration at that particular point. Maybe you may or may not remember there's Primatene Mist that used to be on the market. It was removed in 2011. Part of the reason Primatene Mist was removed, it had ephedra, which is epi, in it. And people were using it. They were buying it and using it. And they would say, I don't have to go to my doctor. I've got this to use. Except sometimes the effect was that people didn't survive from them. There's actually another drug on the market called asmonephrine or something like that. That's the replacement for Primatene Mist. And you can go to the drugstore and take a look at that. So you have your Kehoe theory of your beta-2 specificity. Basically, what we're doing is we're changing the end of these chains. And as we change these ends of the chains of the different drugs, then we get better beta-2 more than beta-1. So how do these drugs get metabolized? For the most part, you have COMT that will do it. It will limit the duration to 1.5 to 3 hours. You can't take the catecholamines orally because, as you can see, it's inactivated in the gut and the liver at that point, okay? Also, you have to protect it from heat, light, and air. If you ever get racemic epi and it's pink, it means it's been inactivated. And so then you have to go ahead and get rid of it at that point. The salinogen agents, these are more beta-2. You can take them by mouth. Albuterol does have a tablet that you can take. The tablets last longer at that particular point. They have the inhaled albuterol peak effect in about 30 to 60 minutes. But we know the onset's in about 15 minutes. And we can actually see it. We can track it. We can listen to these patients. And we have an idea of what's going on at that point. Okay. The thing about giving these drugs, we want to do the inhaled form. And this talked about in chapter 2 and a little bit in chapter 5. It targets the lungs, which is what we want, and we don't have to use as much of the medication, and we don't have all the side effects. If I give you the tablet, it's going to last a little bit longer, takes a little bit longer to onset, but you have more systemic side effects because it's going throughout the entire body. And there's albuterol. It's an MDI, a DPI, nebulizer, syrup, an extended release tablet, all of these different things. One of the things that you're going to learn as we go through this is when you go to the hospital, you need to look in the patient's chart to see what's been ordered for them. And what you're looking for is to see, is there anything duplicated? I remember when I was a student, we were going through the chart, and there was albuterol to be given by small volume nebulizer, but there was also albuterol to be given by tablet. And the physician had finally come in and had taken the tablet away because the patient was complaining about so much nervousness. So you always want to make sure that you watch that so you know exactly what this patient is getting. And there you see onset about 15 minutes, peak 30 to 60 minutes, anywhere from 5 to 12 hours. The tablets last a little bit longer, about 4 to 6 hours by inhalation. There's your levobuterol. This one came out in the end of the 1990s. The FDA went back to the drug manufacturers and basically said, you need to clean up your drugs. You have too many side effects. And so basically it said, you got to come out and do a better job. And that's where levobuterol came onto the market. It's the R isomer of albuterol, okay? It's also called Zopanex. That's its actual generic trade name. Okay, the generic name is levobuterol. It's an MDI nebulizer. It has 4 different doses, as you can see on here. The 0.63 is very equivalent to the 0.5 mLs of albuterol, and so they work basically the same. A lot of your hospitals now do not have levobuterol. One of the things that you'll talk about are formularies. A formulary is a list of drugs that your hospital carries. What a formulary is for you is if you go to your doctor and your doctor says, I'm going to prescribe this drug and I want you to have the brand name. I don't want you to have the generic. Well, if the brand name is not on the formulary, they'll have to call back and say, are you sure? Yep, because you're going to have to pay for that brand name. Okay, so the formulary is the list of drugs that we have. So a little bit about albuterol. It does increase your intracellular calcium concentration. It is blocked by anticholinergic agents atropine. Okay. It does not produce pulmonary or extrapulmonary beta 2 mediated effects, which means it's does what it's supposed to do, okay? It basically enhances the eosinophils production. Remember, eosinophils have to do with, are you having an allergic response, or have you been invaded by a parasite? That's kind of cool. It's metabolized slower, and it's preferentially retained in the lung when we do use it by MDIs. And it is the most common drug you're going to see out there. The side effects, number one side effect is tremor. Tremor, 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 tremor. In case anybody should ever ask you, the number one side effect is tremor. We see less heart rate changes. We see fewer heart rate changes with levobuterol, but not enough to really warrant having that medication on board. There you can see 1.25 milligrams, which is like 0.25 to 5 mLs of levobuterol have a higher peak effect on the FEV1 than racemic albuterol. However, the side effects and everything else were basically the same. So then we have our long-acting beta-adrenergic agents. You have extended release albuterol. There's your salmeterol. Salmeterol is also known as Ceravent. That's its trade name. It was the first one that came out. It's off the market at this particular point in time, especially by itself. One of the long-term effects of this medication, it used to cause wheezing, and unfortunately, that wheezing was bad enough that people had a lot of morbidity and mortality with them. They got worse, and then some of them ended up dying. The problem with the long-term acting agents were basically when they first came out, patients did not understand what they were or how to use them. I remember when I was working, I went to a patient's room. We were talking. She had some company, and I just told her who I was, why I was there, and asked her, how are you doing? She goes, oh, I feel wonderful. I don't need your treatment, and I'm never going to need you guys again because I have my Ceravent. And I'm like, oh, that's unfortunate because Ceravent is not a rescue agent. And unfortunately, what happened is we had a lot of people who adopted that attitude, went home or called 911, and they were found dead with their empty canister of Ceravent in their hands because they had used it. It had caused wheezing, bronchoconstriction, and then they ended up dying as a result of it. Formoterol is kind of an interesting one. This is one of the drugs that when it was delivered had to be refrigerated. It had a 5-minute onset. Now, a 5-minute onset, people go, well, that's wonderful. The thing about it is, though, is that 5 minutes was just the beginning of it. This drug has to last for 12 hours, okay? So you have that 5-minute where you're feeling much better, and then the action of the drug is going to go down, but it's only going to last for 12 hours. By the way, Ceravent also acts for 12 hours. And then you have the other ones that you see here also. So there's your extended release albuterol, and that's your Vosper ER, and these are oral tablets. And as you can see, the time is anywhere from 8 to 12 hours with the tablets. There's your Ceravent discus. Like I said, they're not being marketed by themselves anymore. Ceravent is actually marketed with one of the inhaled corticosteroids. It's called Advair. So if you know anybody who takes Advair, that's what these guys are actually taking. Okay. Slower onset takes about 20 minutes. Time to peak bronchodilating effects, 3 to 5 hours. Okay, so you have this onset, but to get up to where you need to be is going to take quite a while. That's your 3 to 5 hours, and it does last for 12 hours.